Hello friends, welcome to my YouTube channel. Hope all are fine. Today I am studying forensic medicine, starting with toxicology. The science dealing with toxins produced by animals, plants, and microbes is called toxinology. Toxicology is the science dealing with properties, actions, toxicity, fatal dose, detection, and estimation of poisons. Classification of poisons include corrosives like inorganic acids, which include sulfuric acid, nitric acid, organic acids, which include carbolic acid and oxalic acid, alkalis, which include sodium hydroxide, potassium carbonate, ammonia, metallic salts like zinc chloride, copper sulfate, silver nitrate. Next is irritants, which consist of inorganic metals like lead, copper, arsenic, inorganic non-metals like phosphorus, halogens, organic vegetables like abrus, croton, and castor, organic animal like snake venom, insect bites, mechanical poisons like diamond dust, glass powder, pins. Systemic poisons include CNS somniferous, example opiate, CNS inebriants, example alcohol, sedatives and hypnotics, CNS deliriants like datura, cannabis, cocaine, CNS spinal like strychnine, gelsemium, peripheral poisons like curare, conium maculatum, cardiovascular poisons are oleander and aconite, asphyxiants are carbon monoxide and cyanogen gas. Thallium is considered as an ideal homicidal poison because poisoning with thallium resembles natural death. When considering suicide with poison, the suicide victim prefers to terminate life as quickly as possible with the least agony, whereas for an act of homicide with poison, the criminal would like to kill his victim without creating any suspicion in the mind of the victim or people around. Following are the characteristics of ideal suicidal and homicidal poisons. First, talking about suicidal poisons, they are easy and free. Antidotes are not present. Clinical diagnosis is difficult. Cost of the poison is cheap. Metabolism and excretion is not particular. Onset of signs and symptoms in suicidal poisons are quick and fatal. Postmortem detection is difficult. Solubility in food or drinks is positive. Examples of suicidal poisons are opium, cyanide, barbiturates, organophosphorus compounds. Next is about homicidal poisons. It is not particular, that is, the accessibility to the poison is not particular. Antidotes are not present. Clinical diagnosis is difficult. Cost of the poison is not particular. Metabolism and excretion are rapid. Onset of signs and symptoms are slow and fatal. Postmortem detection is difficult. Signs and symptoms resembles the disease. Solubility in food or drink is positive. Examples are arsenic, aconite, thallium, etc. Thallium and organic compounds of fluorine satisfy some of the criteria for an ideal homicidal poison. Arsenic and aconite are commonly used as homicidal poisons but are not considered ideal homicidal poisons. Next case is a farmer is found guilty of leaving his pesticides carelessly in the kitchen. It caused his wife to unknowingly consume pesticides and suffer from poisoning. He would be charged with Section 284 of the Indian Penal Code. This deals with negligent conduct with respect to poisons. The following sections of the Indian Penal Code are related to poisoning. They are Section 284 IPC deals with negligent conduct with respect to poisons. Section 193 IPC deals with punishment for false evidence. Section 304A IPC deals with causing death by negligence. Section 328 IPC is for causing hurt by means of poison with intent to commit an offense. Next case is a man tries to poison his neighbor by adding small amount of rat poison to his food. This man would be charged with Section 328 IPC deals with causing hurt by means of poisons. Section 304A IPC deals with causing death by negligence. Section 324 IPC deals with voluntarily causing hurt by dangerous weapons or means. Section 322 IPC deals with voluntarily causing grievous hurt. Next case is you are a registered medical practitioner working at a PHC. A patient is brought to you with a history of consuming poison in a suicide attempt. All cases of poisoning, whether suicidal, homicidal, or accidental, are categorized under medico-legal cases. In the given clinical scenario, the patient attempts to suicide by poisoning, which is labeled as medico-legal case and warrants the need to inform the police. Considering the legal implications, there may be a biased history from relatives or friends or acquaintances, wherein it is always advisable to report each and every suspected case of poisoning to the police, and the question of suicide or homicide or accident to be considered by the police. The treatment must not be withheld before informing the police. The most rapid onset of action of poison is associated with inhalation in gaseous form or vapors. Routes of administration in the decreasing order of onset of action are inhalation, which is most rapid. Next is intravenous, intramuscular, subcutaneous, intradermal injection, application to a wound, application to a serous surface, application to a mucous surface, ingestion, application to unbroken skin. These all are the routes of administration in the decreasing order of onset of action. Next case is a woman was drugged with a substance which was slipped into her coffee without her knowledge by a man at her workplace. The man confessed that he tried to make her notice him by adding a love filter to her coffee. A love filter is a magical potion that is supposed to make the person who receives the potion love the one who gave it. These are usually aphrodisiacs. Some aphrodisiacs that are used as love filter are cantharides, arsenic, alcohol, opium, cocaine, cannabis. The use of a love filter might lead to accidental poisoning. Next case is during a postmortem examination, the forensic expert reports a peculiar chocolate colored discoloration of the body. It did not blanch on pressure. The chocolate brown discoloration, which does not blanch on pressure, is suggestive of postmortem hypostasis or lividity. It usually develops within 4 hours and persists until putrefaction. Chocolate colored postmortem lividity is associated with nitrates, nitrites, aniline, bromates, chlorates. It is due to the formation of methemoglobin. Toxicity from nitrates can be treated with methylene blue to reverse the formation of methemoglobin. Next is postmortem staining in poisonings along with the color of lividity. Carbon monoxide, cherry red color. Cyanide, brick red or dark pink color. Phosphorus acute copper poisoning, there is dark brown color. In opium poisoning, there is black color. Hydrogen sulfide, there is blue green color. Nitrate, nitrite, aniline, potassium chlorate. Here we can see red brown or chocolate brown color. Potassium cyanide shows deep blue color. Clostridium perfringens infection shows bronze color. Hypothermia shows bright pink color. These are the poisoning with the substances along with the color of lividity. Next case is a deceased man is being evaluated for suspected poisoning. During an autopsy, you get a peculiar garlicky smell from the nose and mouth of the body. This scenario is suggestive of phosphorus poisoning as it is associated with a garlic-like odor, usually around the mouth and nose of the victim. Other substances associated with garlic-like odor are arsenic, thallium carbonate, and zinc phosphide. Next is characteristic odor of toxins. Garlic odor can be seen in arsenic, phosphorus, malathion, thallium carbonate poisoning. Thallium sulfate is the most common and thallium oxide. These both shows odorless. Zinc phosphate gives a garlic odor or rotten fish smell. Cannabis gives odor of burnt rope. Carbolic acid shows phenolic odor. Cyanide gives smell of bitter almonds. Ethyl alcohol gives fruity odor. Hydrogen sulfide gives rotten egg smell. Organophosphorus gives smell of kerosene. Next case is a patient was brought in with a history of consumption of acid. His last meal was 1 hour ago. The pathway that fluids, that is acid, alkali or water, taken in a food-filled stomach is known as mangestrace. It is present along the lesser curvature of the stomach. This is where the greatest damage to gastric mucosa takes place in corrosive injury. In an empty stomach, the maximum injury occurs to the lower half to 2/3 of the body with sparing of the fundus. In sodium amytal poisoning, the capsule stained the stomach mucosa and its contents as turquoise blue. Bluish discoloration of the stomach mucosa is also seen in copper sulfate poisoning. Next is the appearance of gastric mucosa in specific poisons. In arsenic poisoning, we can see red velvety mucosa. In sulfuric acid poisoning, we can see brown or black color with erosion, perforation, and carbonization. In carbolic acid poisoning, we can see grey, leathery, and thickened mucosa. In hydrogen nitrate, we can see yellowish gastric mucosa. Hydrogen cyanide, we can see pinkish gastric mucosa. Potassium cyanide, we can see brick red to brown color of gastric mucosa. In phosphorus poisoning, we can see yellow or grayish white appearance of gastric mucosa. CNS depressants and alcohol are associated with the phenomenon of drug automatism. Drug automatism develops due to the depressant effect of these drugs. It leads to the development of an automatism state where the patient takes additional doses of the drug without realizing it. This can lead to accidental poisoning. Gastric lavage can be performed in case of carbolic poisoning. In carbolic acid poisoning, if the patient survives for 48 hours, there will be carboluria followed by anuria. The victim will pass dark, smoky urine which soon turns olive green on standing due to oxidation of hydroquinone and pyrocatechol. It is a corrosive acid, however, it hardens the gastrointestinal mucosa, producing a leather bottle stomach and anesthetizes the nerve endings. This allows for gastric lavage. Contraindications for gastric lavage are advanced pregnancy, severe heart disease, hypothermic patient, volatile poison, comatose patients, convulsions or CNS stimulants, corrosive poisoning except carbolic acid, upper GI pathology, example esophageal varices. Sulfuric acid and kerosene are corrosives and strychnine is a convulsant. Hence, gastric lavage is not done in these poisonings. Hydrofluoric acid and strong alkalis causes liquefactive necrosis. Oxalic acid, carbolic acid and strong acids causes coagulation necrosis. In strong acids, hydrogen ions penetrate tissues and lead to cell death and scar formation. This prevents further hydrogen ion penetration and protects against deeper injury. Carbolic acid, it is same as other strong acids but also hardens the gastrointestinal mucosa. It produces a leather bottle stomach and anesthetizes the nerve endings, and this allows for gastric lavage. Next is oxalic acid. It is also same as other strong acids but also scavenges the calcium ions, leading to hypocalcemia and calcium oxalate renal stones. Next is hydrofluoric acid. Hydrofluoric acid, here the fluoride ions scavenge the intracellular cations such as calcium and magnesium and inhibit sodium potassium ATPase, disrupting the cell membranes. This leads to hypocalcemia and hypomagnesemia. Strong alkalis like in hydroxide ions easily penetrate the tissues, leading to the dissolution of cell membranes, and this strong alkalis is associated with deep tissue injury. Gastric lavage is not done in a case of kerosene poisoning. It can cause aspiration and pneumonitis. Gastric lavage is rarely indicated as the procedure has numerous complications. It may be considered in cases where there is recent ingestion of life-threatening amounts of a toxin for which there is no treatment once absorbed. With drugs that slow down gastrointestinal motility or cause pylospasm, for example, anticholinergics, opioid salicylates, lavage can be done up to 24 hours. Next case is, you have been asked to administer gastric lavage to a patient with salicylate poisoning. The left lateral position is the ideal position for performing gastric lavage. Position the patient on the left side with the head down at an angle of 20 degrees. The patient's mouth should be at a lower level than the larynx to prevent aspiration. The tube used for performing gastric lavage in patients with suspected poisoning is Ewald tube. It is also known as Boas tube, stomach tube, or orogastric lavage tube. Gastric lavage is the administration and evacuation of small volumes of liquid through an orogastric tube to remove toxic substances within the stomach. In adults, the small amount of warm water or saline are administered and via a siphoning action removed again. In children, normal saline is used as children are more at risk of developing hyponatremia if lavaged with water. In an unconscious patient, gastric lavage is performed after induction of general anesthesia with the patient intubated to prevent aspiration. Next case is a patient presents to emergency department with suspected poisoning. The next best step in the management of the patient with suspected poisoning is to either administration an antidote or enhance the elimination of the poison. The following modalities of gastrointestinal decontamination have been used in the past but are no longer routinely recommended are emetics, cathartics, dilution, gastric lavage. Dilution was historically recommended following the ingestion of acidic or alkaline corrosives to decrease the concentration and prevent tissue damage. Gastric lavage is rarely indicated as it is associated with high rates of complication. Next case is a 20-year-old woman was rushed to emergency department due to an attempted suicide by ingesting an unknown substance. Activated charcoal is not effective in case of poisoning with heavy metals like lead, corrosive, cyanide, hydrocarbons and alcohol. Indications for use of activated charcoal are ingestion within the previous 1 hour except in case of poisons that slow gastric emptying or after ingestion of a substance that leads to bezoar formation. It may be given after 1 hour. The toxic substance should be known to be absorbed by activated charcoal. The benefits of administration should outweigh the risk. Contraindications to use of activated charcoal are non-toxic ingestion, toxin not absorbed by activated charcoal, unprotected airway, possibility of upper GI perforation. Multi-dose activated charcoal is used for the enhanced elimination of a toxin. In some instances, patients may benefit from the repeated administration of activated charcoal. MDAC, that is multi-dose activated charcoal, facilitates the passage of substances from plasma into the intestinal lumen, enhancing elimination. Currently, MDAC, that is multi-dose activated charcoal, is indicated for only the following poisons like quinine, dapsone, salicylates, phenobarbital, theophylline, and carbamazepine. Dimercaprol or BAL, BAL. It is an antidote for gold, arsenic, or acute mercury poisoning. Except in arsen as well as except in non-alkyl mercury, we can use BAL as an antidote. It is also an adjunct to irritate calcium disodium in acute lead poisoning. Dimercaprol has also been approved by the FDA to treat Wilson's disease, but not acute copper poisoning. The use of dimercaprol in the management of poisoning for other heavy metals has not been validated. Next case is a 35-year-old man presents with complaints of constipation, abdominal cramps and tingling in the extremities. His blood work shows a lead level of 50 microgram per deciliter. The given clinical scenario is suggestive of lead poisoning. Calcium EDTA and DMSA, which is also known as Succimer, are the preferred antidotes for lead poisoning. In a patient highly exposed to lead, chelation with oral DMSA is recommended. In case of acute poisoning with encephalopathy, IV or IM calcium EDTA is given along with dimercaprol. Calcium EDTA redistributes lead to the brain and increases the risk of leading to encephalopathy, which is prevented by dimercaprol. Lead poisoning is also known as plumbism and it is also known as saturnism. Lead toxicity, source of exposure is lead paint. That means it is through occupational exposure. Route of absorption for lead toxicity is in children it is through GI tract and in adults it is through respiratory tract. Mechanism of action is lead binds to sulfhydryl groups and inhibits ALA dehydratase and ferrochelatase. It inhibits pyrimidine 5' nucleotidase, competes with calcium. Organs affected, that is acute toxicity of lead, it mainly affects the organs like GI tract, bone marrow and peripheral nerves. Chronic toxicity for lead, that is organs affected through chronic lead toxicity are CNS and kidney. Characteristic clinical findings are anemia with basophilic stippling, Bertonian line, that is blue stippled line on gums, constipation and abdominal pain, wrist drop and foot drop due to neuropathy, E for encephalopathy, which is mostly seen in infants presenting with severe ataxia, vomiting, lethargy, stupor, convulsions and coma, And the earliest sign for lead toxicity is facial pallor. Diagnosis is through blood lead levels. Treatment is through calcium EDTA and DMSA, that is succimer. Urinary alkalinization, which is also known as forced alkaline diuresis, is most effective for weak acids primarily eliminated by the renal tract. It is performed with sodium bicarbonate. Acetazolamide should not be used to produce alkaline urine because it may worsen toxicity by causing a concomitant systemic acidosis. It results in an increase in the amount of unionized drug in the blood and enhanced tissue distribution. It may also compete with acidic drugs for tubular secretion and thereby inhibit their elimination. Drugs most commonly treated with forced alkaline diuresis are salicylates and phenobarbital. Forced acidic diuresis is not indicated in any scenario as its potential risks such as rhabdomyolysis, acute renal injury, these all outweigh any potential benefits. Hemoperfusion uses adsorbents like a charcoal filter which comes into direct contact with blood, partially overcoming molecular weight and protein binding limitations. Properties of toxins to be considered for hemodialysis are: toxin requirements are low volume of distribution, low protein binding, low endogenous clearance, and low molecular weight. Indications of hemodialysis are salicylates, lithium, alcohol, and metformin. Next is toxin requirements of hemoperfusion are of low volume of distribution, low endogenous clearance. It is bounded by activated charcoal. Indications for hemoperfusion are theophylline and carbamazepine. Next topic is OP poisoning. Endrin is an organochlorine compound. Poisoning with this compound causes mydriasis. There is no specific antidote for organochlorine poisoning. Diazinon, phosdrin, and paroxone are organophosphates and they cause meiosis. Organophosphate poisoning is treated with atropine and oximes. Classification of insecticides include organophosphorus compounds like parathione, paraoxone, chlorthione, diazinon, malathione, phosdrin, HETP, TEPP. Organochlorine compounds like DDT, gamma hexachlorobenzene, endrin, aldrin, endosulfan. Carbamates like aldicarb, carbaryl, carbofuran, and next is pyrethrin and pyrethroids. These all are the classification of insecticides. Next case is a 36-year-old woman presents to casualty with diarrhea, meiosis, and altered sensorium. Her husband reveals that she has ingested rat poison in an attempt to commit suicide. The given clinical scenario is suggestive of organophosphorus poisoning. Clinical effects are due to inhibition of acetylcholinesterase. Inhibition of cholinesterase leads to the accumulation of acetylcholine at the nerve synapses and neuromuscular junctions. This results in overstimulation of acetylcholine receptors, resulting in a cholinergic crisis. Acetylcholinesterase or RBC cholinesterase is helpful in the diagnosis of OP poisoning but has no prognostic significance. It is hypothesized that inhibition of neuropathy target esterase enzyme may be responsible for organophosphate-induced delayed neuropathy. Mechanism of action of carbamate is carbamylation of carboxylic esterase. Mechanism of action of chlorate salts like sodium or potassium chlorate is oxidation of hemoglobin to methemoglobin. Mechanism of action of paraquat is free radical mediated damage. Intermediate syndrome is unresponsive to atropine and oximes. It occurs due to prolonged cholinesterase inhibition and muscle necrosis. 4 clinical syndromes are identified with respect to organophosphate exposure. They include acute poisoning, intermediate syndrome, chronic toxicity, organophosphate-induced delayed neuropathy. First of all, about acute poisoning, this results in CNS, muscarinic, nicotinic, and somatic motor manifestations. Next is intermediate syndrome. It is usually observed 1 to 5 days after OP exposure. It is characterized by paralysis of neck flexors, muscles innervated by cranial nerves, proximal limb muscles, and respiratory muscles. Next is chronic toxicity. It is seen primarily in agricultural workers with daily exposure. It manifests as symmetrical sensorimotor axonopathy. Next is organophosphate-induced delayed neuropathy. This is characterized by cognitive dysfunction, extrapyramidal symptoms, and peripheral neuropathy. It can lead to flaccid paralysis and muscle wasting. Next case is a 25-year-old woman who was admitted with accidental rodenticide ingestion was started on atropine. Atropinisation in organophosphate poisoning or rodenticide poisoning does not cause regression of nicotinic symptoms like muscle cramps. Hence, oximes are used for the reversal of nicotinic symptoms. Atropine is effective against muscarinic receptors. It can be used to treat muscarinic symptoms like bradycardia, urinary incontinence, and hypotension. Drugs used in organophosphorus poisoning are if the symptoms are muscarinic symptoms and there is CNS effects, atropine should be given. If there is nicotinic symptoms, pralidoxim should be given. If nicotinic more than muscarinic and CNS effects are seen, diacetyl monoxim is given. It is the specific cholinesterase reactivator. If convulsions are present, IV diazepam is given. If pulmonary edema, bronchospasm, these are present, oxygen, atropine, intubation, positive pressure ventilation should be given. Next case is a local informer revealed that decades old nerve gas cylinders were being smuggled across the border. On arrival of the police at the crime scene, the accused opened fire. One of the bullets accidentally impaled the canister near the police officer. Nerve gases are organophosphate compounds in the gaseous form. It manifests with cholinergic signs and symptoms such as meiosis. It was used in chemical warfare. The nerve gases include soman, sarin, tabun, and 510 Roman letters 5 and 10. Next case is a 45-year-old woman who is being treated for organophosphate poisoning with atropine is started on pralidoxim. Pralidoxim causes reversal of tongue fasciculations, which is nicotinic symptom. Since atropine does not bind to nicotinic receptors, it is ineffective in treating neuromuscular dysfunction. Pralidoxim and other oximes such as HI6 and obidoxim are cholinesterase reactivating agents. Hence, its co-administration with atropine is effective in treating both muscarinic and nicotinic symptoms. Pralidoxim reactivates the acetylcholinesterase, which has been activated in organophosphate poisoning. Pralidoxim attaches to the anionic site of the enzyme that remains unoccupied. Then it reacts with the phosphorus atom of the organophosphorus compound, which is attached to the esteric site to form a phosphooxime complex. It then dissociates from the enzyme, regenerating the active enzyme. Pralidoxim should not be administered without concurrent atropine in order to prevent worsening of symptoms due to transient oxime-induced acetylcholinesterase inhibition. Muscle cramps are nicotinic symptoms, however, abdominal cramps are muscarinic symptoms. There is no specific treatment for the intermediate syndrome in OP poisoning. The intermediate syndrome is seen in 20 to 50% of acute OP poisoning cases. This syndrome develops 1 to several days after the poisoning during the recovery from cholinergic manifestations. In some cases, it can occur when patients have completely recovered from the initial cholinergic crisis. Clinical features include paralysis of neck flexor muscles, proximal limb muscles, muscles innervated by the cranial nerves, and respiratory muscles, that is, respiratory support may be needed. Symptoms or signs of cholinergic excess are absent in this syndrome. There is no specific treatment for the intermediate syndrome and intervention is exclusively supportive. Next case is a 38-year-old gardener presents with blurred vision, breathlessness, and muscle fasciculations. He gives a history of spraying the solution, that is malathion 50%, a day prior to his symptoms. The given clinical scenario is suggestive of malathion, which is organophosphate poisoning. In this condition, prolonged QTC interval is a non-specific finding. However, it correlates with the severity and mortality in severe cases. The reliable indicators of OP poisoning are meiosis and muscle fasciculations, decrease in RBC cholinesterase levels, absence or resolution of cholinergic symptoms after an initial dose of atropine. Next case is you are suspecting OP poisoning in a farmer who presented with chronic fatigue and urinary incontinence. RBC cholinesterase enzyme activity is the most accurate indicator to assess potential OP toxicity. It is an indicator of synaptic cholinesterase inhibition. However, plasma butyryl cholinesterase is easier to assay and more easily available. Hence, it is most commonly used. Measurement of parent compound in blood and metabolites, urine are rarely carried out in a clinical setting. In organophosphorus poisoning, clinical signs and symptoms are observed when pseudocholinesterase level falls below 50% of normal. Severity of symptoms correlates with pseudocholinesterase levels are as follows. If there is mild severity of OP poisoning, the level of pseudocholinesterase is 40 to 50%. If there is moderate severity of OP poisoning, the level of pseudocholinesterase is 10 to 40%. When there is severe severity of OP poisoning, the level of pseudocholinesterase is less than 10%. Next case is a 7-year-old girl is rushed to the casualty in an unconscious state as she has consumed and chalks 2 hours ago. On examination, you note the presence of meiosis and crackles on chest auscultation. She is hypotensive with pulse rate of 50 beats per minute, respiratory rate of 36 per minute, and ECG showing prolonged QTC. You start treating her with atropine sulfate IV. The given clinical scenario is suggestive of acute OP poisoning, which is treated with atropine sulfate. Clear chest on auscultation indicates clearing of tracheobronchial secretions and cessation of bronchoconstriction. Hence, it is considered as the therapeutic endpoint of atropinization. Tachycardia and mydriasis are not appropriate markers for therapeutic improvement, as they may indicate continued hypoxia, hypovolemia, or sympathetic stimulation. Treatment of OP poisoning include decontamination, airway management, stomach wash with water with or without KMNO4, atropine sulfate at dose of 2 to 4 mg IV, which is highly effective in counteracting the peripheral muscarinic effects and antagonize the CNS effects at higher dose. Next is oximes, which is used early as they have more pronounced action on nicotinic sites. Oxygen supplementation has proven clinical and mortality benefits in patients with OP poisoning who develop respiratory failure. Pralidoxim is not beneficial in terms of reducing mortality, need for ventilator support, and incidence of intermediate syndrome. Despite theoretical and experimental benefits and clinical use worldwide, the current evidence is inadequate. However, until further research has been undertaken, all patients poisoned with OP agents are recommended to be treated with an oxime. Urinary alkalinization, hemodialysis, and hemoperfusion have no role in the treatment of OP poisoning. Gastric lavage and activated charcoal administration are beneficial only in patients who present within 2 hours following ingestion of OP compounds. The most common cause of death in organophosphate poisoning is respiratory failure. It usually occurs within 24 hours in untreated patients secondary to paralysis of respiratory muscles. Carbamates can also lead to the intermediate syndrome. Carbamate cholinesterase bond undergoes rapid spontaneous hydrolysis, which leads to regeneration of the enzyme within a few hours. This is called reversible carbamylation. Hence, aging, that is conversion of the inhibited enzyme into a non-reactivable form, does not occur, and the effect of carbamate toxicity is of a shorter duration. Carbamates do not effectively penetrate the CNS in adults, hence there is less CNS toxicity. Pralidoxim is contraindicated in carbamate poisoning because it may potentiate the toxicity of carbamates due to its transient oxime-induced cholinesterase inhibition. Next is alcohol poisoning. Isopropyl alcohol causes the most inebriation. Inebriation or drunkenness caused in the descending order is isopropyl alcohol, ethyl alcohol, methyl alcohol. Toxicity or organic damage caused in descending order is isopropyl alcohol, methyl alcohol, ethyl alcohol. All alcohols cause clinical inebriation such that the intensity of its inebriating effect is directly proportional to its molecular weight. Molecular weight of methanol is 32, molecular weight of ethanol is 46, molecular weight of isopropanol is 60, molecular weight of ethylene glycol is 62. High protein food retards absorption of alcohol. Food, especially fats and proteins, decreases absorption. The following factors enhance absorption of alcohol. They are empty stomach, strength of alcohol drink, carbonated drinks, that is the bubbles greatly increase the surface area carrying alcohol. Next is warm alcohol drinks, that is warm drinks dilate gastric mucosal capillaries and are quickly absorbed. There are no significant gender differences concerning renal elimination affecting the blood alcohol concentration levels. Blood alcohol concentration following the ingestion of ethanol is influenced by many factors. These include weight, body fat percentage, gastric alcohol dehydrogenase. First is weight, that is, women on average are smaller than men, so have less fluid in their bodies for alcohol distribution. Next is body fat percentage. Since women have greater body fat, their aqueous compartment is smaller and hence they achieve a higher blood alcohol concentration. Gastric alcohol dehydrogenase, that is, some ethanol is broken down in the stomach by gastric alcohol dehydrogenase, which lowers the amount available for absorption. This enzyme is present at higher levels in men than in women. Next case is a 25-year-old man with acute alcohol intoxication was being tested in emergency department. When stimulated by pinching, his pupils dilated with a slow return. The given scenario is suggestive of McEwen's sign. Pupils are contracted, but stimulating the person, like for example pinching or slapping, causes them to dilate with a slow return. This is a characteristic finding of ethanol toxicity seen at blood alcohol concentration level more than 250 milligram percentage. Tremors or tremulousness or shakes or jitters is the most common sign of alcohol withdrawal. This occurs about 12 to 24 hours after their last drink. Effects of alcohol withdrawal include weakness, tremors, insomnia, loss of appetite, vomiting, diarrhea, restlessness, exaggerated reflexes, fluctuating BP, and hallucinations. Snowfield vision is seen in methanol poisoning. Consumption of excess alcohol is associated with holiday heart syndrome, Marchia-Fava-Bignami syndrome, and Wernicke-Korsakoff syndrome. Holiday heart syndrome is seen after an episode of heavy drinking. It presents with cardiac arrhythmia, that is atrial fibrillation or ventricular arrhythmia. And this excess alcohol is associated with Marchia-Fava-Bignami syndrome. Marchia-Fava-Bignami syndrome is caused by widespread demyelination of the corpus callosum, optic tract, and cerebellar peduncles. It is characterized by disorientation, epilepsy, ataxia, dysarthria, hallucinations, spastic limb paralysis, personality and intellectual deterioration. Wernicke-Korsakoff syndrome is characterized by Wernicke's encephalopathy, which includes nystagmus, ophthalmoparesis, confusion, and ataxia, and also Korsakoff psychosis, which includes memory loss and confabulation. Next case is a 30-year-old man is brought to the emergency department with complaints of excessive vomiting following alcohol ingestion. On examination, you notice slurred speech and horizontal gaze nystagmus. In isolated ethanol intoxication, the occurrence of horizontal gaze nystagmus indicates a blood alcohol concentration level of around 80 mg per deciliter. It has a 70 to 80% sensitivity. Horizontal gaze nystagmus has been shown to correlate highly with both blood alcohol concentration as well as cognitive impairment. The HGN test, that is horizontal gaze nystagmus test, assesses the lack of smooth pursuit, sustained endpoint nystagmus, and induced nystagmus prior to a lateral gaze angle of 45 degrees. When blood alcohol concentration is in between 0 to 50 milligram percentage, there will be no significant or mild euphoria. When blood alcohol concentration is in between 50 to 100 milligram percentage, there will be decreased inhibition, increased self-confidence, decreased attention span, slurring of speech, alteration of judgment, and nystagmus. When blood alcohol concentration is in between 100 to 150 milligram percentage, there will be mental confusion, emotional instability, loss of critical judgment, ataxia, impaired memory, and sleepiness. When blood alcohol concentration is in between 150 to 300 milligram percentage, there is loss of muscular coordination, staggering gait, drowsiness, exaggeration of emotions, dizziness, disorientation, and decreased pain response. When blood alcohol concentration is in between 300 to 400 milligram percentage, there will be stupor, marked incoordination, possibly coma. When blood alcohol concentration is 400 milligram percentage and above, there will be anesthesia, depression of response, respiratory failure, deep coma, and death. Gas liquid chromatography is the most reliable method for the assessment of blood alcohol levels. The test used for estimation of alcohol concentration can be classified as follows. Chemical test example is Widmark method, Cavett method. Biochemical test example is ADH method. Physical test example is gas liquid chromatography. The most accurate breath analyzers work based on the principle of infrared spectrophotometry. Infrared spectroscopy is the measurement of the interaction of infrared radiation with the matter by absorption, emission, or reflection. Next case is a man is heartbroken because his girlfriend recently left him to marry another man. He decides to get drunk that night to cope with his feelings. On waking up the next morning, he finds that he has set fire to her car. This man can be charged under Section 435 IPC. According to Section 435 of Indian Penal Code, whoever commits mischief by fire or any explosive substance intending to cause or knowing it to be likely that he will thereby cause damage to any property to the amount of 100 rupees or upwards. Next is Section 84 IPC. It is act of a person of unsound mind. No act is an offense which is undertaken by a person who, at the time of doing it, by reason of unsoundness of mind, is incapable of knowing the nature of the act or understanding of what is being done, is either wrong or contrary to law. This does not apply to the man who was not of unsound mind. Section 84 IPC does apply in the case of delirium tremens. Next is Section 85 IPC. No act is an offense which is done by a person who, at the time of doing it, by reason of intoxication, is incapable of knowing the nature of the act or what he is doing is either wrong or contrary to law, provided that what intoxicated him was administered to him without his knowledge or against his will. Here Section 85 IPC does not apply because the alcohol was not administered to him against his will. Next is Section 510 IPC. Misconduct by a drunken person in public is punishable with imprisonment of up to 24 hours. This does not apply here as the man was not caught while committing the crime while in a state of intoxication. Metadoxin enhances the metabolism of alcohol. It is reported to double the rate at which ethanol blood levels decrease with time compared with the patients on metabolism. Next case is a 26-year-old man dies due to accidental poisoning after consumption of illicit liquor containing methanol. Huge tragedy may occur due to consumption of the cheap illicit liquor containing methanol, which is often a component of butyl-egged alcohol, particularly by the lower socio-economic classes. Next case is a patient with calcium oxalate monohydrate crystals in the urine is diagnosed with ethylene glycol poisoning. Fomepizole is the drug of choice for the treatment of ethylene glycol poisoning. Treatment of ethylene glycol poisoning include fomepizole, which is the preferred drug, or ethanol if fomepizole is unavailable. It inhibits the enzyme alcohol dehydrogenase. Next is sodium bicarbonate. It corrects the systemic acidosis. Next is hemodialysis. It is used for elevated toxic alcohol levels, severe acid-base derangements, or evidence of end organ toxicity. Cofactors, that is folic acid, thiamine, and pyridoxine. These optimizes non-toxic metabolic pathways for the elimination of parent alcohol or its metabolites. Next case is a 30-year-old drowsy male was brought to the casualty. His pulse was 130 per minute. Respiratory rate 30 per minute. His lab reports are ABG showed metabolic acidosis. Total serum calcium showed 6.8 mg per deciliter. Blood urea is 100 mg per deciliter. Creatinine is 3.4 mg per deciliter. Urine analysis showed calcium oxalate crystals. He showed improvement on nasogastric aspiration and administration of sodium bicarbonate, calcium gluconate, and 4-methylpyrazole. The given scenario point towards ethylene glycol poisoning. Ethylene glycol is converted to glyoxyaldehyde by alcohol dehydrogenase. Glyoxyaldehyde causes kidney damage. Methanol is converted to formaldehyde by alcohol dehydrogenase. Formaldehyde causes retinal damage like blurring of vision or loss of vision. The principle of treatment for both these conditions are the same. It predominantly involves using fomepizole or ethanol to inhibit the metabolic conversion of these relatively non-toxic alcohols to their toxic metabolites. Ethanol has a higher affinity for alcohol dehydrogenase than methanol. Hence, the metabolism of methanol is slowed down on ethanol administration. Formic acid, the metabolite of methanol, is highly toxic. Therefore, slowing down the metabolism reduces the toxic effects. Next case is a 28-year-old man is brought to the casualty by his friend with complaints of vomiting and blurring of vision. On further probing, his friend gives the history of the consumption of a bottle of illicit liquor. His ABG showed high anion gap metabolic acidosis. The given scenario is suggestive of methanol poisoning. Hemodialysis is effective and used in severe cases. A serum methanol concentration greater than 50 mg per deciliter is an indicator for hemodialysis. It can be used to remove both methanol and its toxic metabolite formic acid from the blood. Fomepizole, it is an alcohol dehydrogenase inhibitor which is indicated in methanol toxicity. It acts by inhibiting the formation of toxic formic acid. Intravenous ethanol is an alternative to fomepizole. It has a higher affinity to alcohol dehydrogenase than methanol. Therefore, a saturation of ADH enzymes results in less formation of toxic formic acid. Next topic is medico-legal autopsy. Corpus delicti, it is also known as the body of offense, says that a crime must be proved to have occurred before a person can be convicted of committing that crime. The main part of corpus delicti is the establishment of the identity of the dead body and infliction of violence in a particular way at a particular time and place by the person or persons charged with a crime and none other. A conviction for an offense does not necessarily depend upon the corpus delicti if there are eyewitnesses or strong corroborative evidence. In a charge of homicide, it includes positive identification of the dead body of victim and proof of its death by a criminal act of the accused. In the case of a medico-legal autopsy, consent of the relative is not required. For conducting a medico-legal autopsy, legal authorization is a must. Magistrate is the authorizing officer in case of exhumation. Preferably, a forensic pathologist or medico-legal expert does the autopsy. However, in India, due to lack of adequate qualified experts, all registered medical practitioners can perform this with authorization by the state. In deaths due to RTA, autopsy is usually performed in an equipped mortuary. An autopsy may be performed at the site of recovery of the body in the following scenarios, like advanced stage of putrefaction, as materials of evidentiary value may be lost during transportation, and exhumation, and if the district magistrate desires it to be conducted at the site due to some law and order problems. In all these cases, autopsy may be performed at the site of recovery of the body. An autopsy is preferably performed in an equipped mortuary. Next case is the police hands over the body of a person who died due to hanging to you for an autopsy. The incision preferred in the case of asphyxial death due to neck compression is the modified Y-shaped incision. In strangulation, hanging, and any condition where the larynx might be damaged, a modified Y-shaped incision is to be preferred. This incision is used because the skin of the upper neck can then be dissected off the mandible and raised to give a wide approach to the neck structures. Next case is you observe a forensic surgeon doing en masse removal of organs during an autopsy. The en masse removal of organ is done in the Letule technique. It is the removal of the cervical, thoracic, abdominal, and pelvic organs as a single organ mass. They are subsequently dissected into organ blocks. Types of incision done for an autopsy are Y-shaped incision. It commences at anterior axillary fold on the chest on either side. It runs downwards and anteriorly beneath the breast as to meet at the sternum in the midline. It then runs downwards as in an eye-shaped incision to the pubic symphysis. It is preferred in females. It is more cosmetically accepted as the incision and the stitches are minimally seen after the autopsy. Next is modified Y-shaped incision. It is an incision which is made in the midline from the suprasternal notch to the pubic symphysis. The incision extends from the suprasternal notch over the clavicle to its center on both sides and then passes upwards over the neck behind the ear, indicated in cases of strangulation or death due to compression of the neck. Next is eye-shaped incision. It extends from symphysis menti to symphysis pubis, taking curve towards left around the umbilicus. It is used routinely in practice. It is simple and convenient. Next is elongated X-shaped incision. This is a special incision used to dissect out subcutaneous structures in the back to identify and evaluate the extent of blunt injuries, which are usually missed where superficial imprints are faint, particularly when present on skin not overlying bone. This is to helpful in the reconstruction of events prior to death and should be practiced in case of custodial death. Next is inverted Y-shaped incision. It is used in infants. Cause of death remains unknown even after detailed lab investigation is negative autopsy. When there is no definite cause of death after an autopsy, further evaluation is needed. This is obscure autopsy. Cause of death is assessed by non-invasive methods. Here we do is virtual autopsy. Clinical autopsy is done for academic purpose. Negative autopsy, it is an autopsy in which the cause of death remains unknown even after all lab examinations including biochemical, microbiological, virological, microscopic and toxicological examination is done. Obscure autopsy is an autopsy done meticulously but presents with no clear-cut findings as to give a definite cause of death. Further lab investigations are required to know the details of the cause of death in this type of autopsy. In Breslau's second life test, which is also known as the stomach bowel test, the stomach and the duodenum are tested. This test is done to determine whether the baby was born alive or not. It works on the principle that some air is swallowed during respiration in a live-born child. Procedure is the stomach and duodenum are removed separately and placed in water. If they float, make a small cut while underwater to see air bubbles coming up. A floating viscera giving out air bubbles when opened underwater is a positive test. Interpretation is a positive test proves live birth even in the absence of a positive hydrostatic lung test. This may happen if there had been some obstruction in the respiratory passages. A negative test does not mean stillbirth since air does not necessarily enter the stomach in adequate amounts during the breathing act. Putrefaction invalidates the result. Breslau's first life test is when the same test is performed on the lungs. It is also known as hydrostatic test or flotation test or Raygaard's test. In Raygaard's test, an unrespired lung, that is stillbirth cases, the unrespired lung may float due to gases of decomposition as seen in putrefaction. It is also known as flotation test or Breslau's first life test or hydrostatic test. It is done to determine whether the newborn has respired or not. If the lung pieces float in water, it means that respiration has taken place, indicating a live birth. If the pieces sink, respiration has not taken place, which signifies stillborn. A respired lung, that is live birth cases, the respired lung may sink in water in the following conditions like lung edema, lung collapse, pneumonia, that is consolidation, congenital syphilis. Other tests to determine if respiration has taken place or not are Fodere's test, that is weight of the lungs before respiration is 30 to 40 gram and after respiration it is 60 to 66 gram. Next is Plockett's test, that is weight of lungs before respiration is 1 by 70 of body weight, after respiration it is 1 by 35 of body weight. Redin's test, it assesses the changes in the middle ear. The gelatinous substance in the middle ear is replaced by air if respiration has taken place. Hydrostatic test or flotation test or Raygaard's test. Principle is respired air remains in the lung as residual air which cannot be removed after death. Hence lung floats in water. False negative test is seen in atelectasis, pulmonary edema, pneumonia, congenital syphilis, obstruction by alveolar duct membrane, more air exhaled from the lungs compared to air entering during inspiration, air absorbed from air passages if circulation continued for long time after cessation of respiration. False positive test is seen in putrefied fetus, artificial inflation. Hydrostatic test is not required when fetus is monstrous, when fetus is macerated or mummified, when fetus is born before 180 days of gestation, and when stomach contains milk, or when umbilical cord has separated and scar has been formed. Next case is an ASHA worker brings the body of a newborn to casualty saying that the child was delivered dead at home. You suspect it as live birth and request an autopsy. The absence of meconium in the large bowel is a confirmatory sign of live birth. Confirmatory signs of live birth include presence of milk in the stomach, absence of meconium in the large bowel, exception being breech delivery, exfoliation of skin, closure of fetal channels, and changes in the umbilical cord. Live birth can be excluded if signs of maceration are present, signs of immaturity are present. If the child has not attained the viable age, that is 7 months, it could not have been born alive. A second autopsy may be performed when relatives are not satisfied, new circumstances emerge, or investigating officer demands it. After an autopsy, when a repeat medico-legal postmortem is performed with the authorization by law, it is called a second autopsy. The magistrate or commissioner of the police vested with such power orders the second autopsy. A second autopsy may be performed in the following cases like the investigating authority demands a second autopsy for setting the investigation on the right track, or if the first autopsy was not performed in the light of the circumstances which are now available, or if the relatives of the deceased are not satisfied with the first autopsy report and they have pointed out certain lapses in the first autopsy. In all these cases, a second autopsy may be performed. Arsenic can be detected even in conflagrated human bones. Hence, it is possible to detect poisoning by arsenic even when the body has been burnt for a long time. Arsenic is volatile, but much of the arsenic in bones is converted into arsenates, which are non-volatile. In suspected case of poisoning by arsenic, all the available ashes and burnt bones should be preserved for chemical analysis. Next case is a person died following bee stings. The given case is of a suspected anaphylactic death in which tryptase is of diagnostic value. The postmortem diagnosis of anaphylaxis remains difficult due to the lack of specific biomarkers. Mast cell tryptase, that is MCT, or tryptase, is a sensitive measure of mast cell activation, and high levels will be found after severe anaphylactic reactions, especially those causing severe shock. Diagnostic tests for suspected anaphylactic deaths are serum tryptase and radioallergosorbent testing, that is RAST for IgE.